purpose of this talk, I think, has been to kind of sensitize the coupling of the possibility that you can have seizures in patients with stroke. So the fact is that both can happen together, and there could be certain entities which form an overlap between stroke and epilepsy. And I would be covering my talk in two parts. One is I'll be talking about the overlaps, and the second is, of course, a more challenging management problem of seeing seizures with stroke. Well, epilepsy is something which happens out of the blue, and so does stroke. It is just a bolt out of the blue, whether it's stroke and epilepsy. And we know the difference between epilepsy and stroke is epilepsy is, unprovoked recurrent seizures. They come suddenly and they go suddenly, but of course it's of shorter duration. So what could make us confuse us whether this is really seizures or epilepsy or stroke? The fact is that there can be certain seizures which have certain postictal or interictal states, or have a ictal continuum, and these could mimic stroke or vice versa. So you could have a patient with seizures, particularly focal seizures coming from the perirolandic cortex, and this patient could end up with a Todd's palsy. Typically a Todd's palsy lasts for a few minutes, typically 2 minutes to 5 minutes, rarely 22 minutes or so, but very rarely it can last for a day. So that's where it's going to last for 22 minutes and more than 22 minutes, and you're going to have a deficit. You may confuse it with a stroke. The second, of course, is wherever you find a patient convulses in sleep, and so the seizure is unwitnessed, and the patient wakes up with a postictal deficit. So there again, you could confuse the hemiparesis, which is a postictal paresis, to be that of a stroke or a wake-up stroke. So that's the second confusion. The third is, of course, when a patient has a non-convulsive status, and this is particularly in the elderly, when non-convulsive status can have non-convulsive motor manifestations. So there are no motor manifestations, but there is a permanent aphasia which lasts for a few hours. So there is an aphasic non-convulsive status, or there could be a non-convulsive status which is a hemiplegic non-convulsive status, which is a rarer manifestation of non-convulsive status, particularly coming from certain areas of the brain. Whenever seizures arise from the inhibitory motor cortex, and there are two inhibitory motor cortices in the brain, the first is situated just anterior to the Broca's area. So if the seizure is arising from this, it's a non-convulsive status arising from the area which is the inhibitory motor cortex in front of the Broca's area. And second, of course, is the area which is in front of the supplementary motor area, which is the second negative motor area of the brain. So if seizures are coming from here and are non-convulsive, you're going to confuse it with a stroke. So that's the second thing which I would like you all to remember. And of course, it is a fact that many a times a stroke can manifest with seizures. So the first manifestation of the stroke could be a seizure. Very commonly, it is thought that embolic strokes will present with seizures, so also hemorrhagic strokes, so also cerebral venous thrombosis. So these are kind of overlaps where you could mistake a seizure to be a stroke. Not so uncommon, though it's rare, not so uncommon is another overlap, which is the transient global amnesia. Now, this is not even recognized as a vascular phenomenon. There's a lot of confusion about this entity. So here you have an elderly, typically you have an elderly male person who is amnestic. He's completely amnestic. He doesn't know what's been told a few minutes to a few hours before, but he's fully conscious. He's conscious and aware of who he is. He's conscious and aware of who others around him are. But he's amnestic. So there is a cognitive manifestation of a vascular phenomenon. And it's a most misunderstood entity. I have seen personally 3 patients in my 25-year-old long career as a neurologist. And of course, what has been hypothesized is, could it be that those patients who have migraine have a possibility of having transient global amnesia later on in life? Or could it be truly a transient ischemic attack which is prolonged in the posterior circulation territory, which affects the mesial limbic structures, causing a transient hypometabolism of the mesial limbic structures, causing amnesia, but no altered sensorium? So a vascular hypothesis which has been substantiated by doing nuclear imaging, by doing PET scans, by doing functional MRI studies, which have shown a hypoperfusion in these areas. Generally, transient global amnesia lasts for less than a day. To conflict with this is another mimic which could mimic transient global amnesia and a vascular state. Herewith is the transient epileptic amnesia, which is a term coined by Dr. Kapoor from the United Kingdom. And transient epileptic amnesia, unlike transient global amnesia, again I've seen at least 1 or 2 Ts every year. So this is much more common than TGA. And here it's shorter than TGA. It's going to last for a few seconds to minutes, max a few hours. The person has complete amnesia. It's anterograde amnesia. And because these events go undetected, they are so brief, there can be a cumulative cognitive deficit. So if you see a T patient, say about 1 year into the T, there are going to be cognitive deficits associated and cognitive decline. There's a high frequency of these episodes. Many of these episodes occur upon awakening. So they are just passed off as confusional states because, you know, there is a parasomnia known as confusional arousal. So very often Ts get misunderstood as confusional arousal. And of course, the person cannot remember who's around them and who they are, and they're amnestic. Unlike TGA, where a TGA person knows who he is and who's around him. There's a general approach to these TEAs. The first is whenever you're suspecting TEA stroke overlap, please get an EEG done because that's going to give you an important clue when you find the epileptiform discharges. And once you find these epileptiforms, whether they are focal or whether they are repetitive, if it's a prolonged T, you will get repetitive discharges. If you have a facility of doing nuclear imaging, you can show a selective hypometabolism in the temporal lobes, again in TEAs. And the beauty about this hypometabolism is that if the TEA is associated with intact awareness, then it's coming from the non-dominant temporal lobe, which reverses on reversal of the T. Of course, once you pick up these discharges, you're bound to treat with anti-epileptic drugs. The next overlap is, of course, the limb-shaking TIAs, not so uncommon, seen about once or twice a year. I'm sure the stroke specialists see it much more often. And this is actually an asterixis, and this is, kind of brought about by impaired circulation because of severe carotid occlusion. So wherever you have a limb-shaking TIA, you have to get a vascular, at least an ultrasound or a vascular imaging to substantiate it. Not uncommon, apart from severe carotid occlusion, is the fact that patients with moya disease can present with limb-shaking TIAs and mistakenly get put on anticonvulsants. Hence, it would be worthwhile doing EEG in your moya diseases. Please do not do hyperventilation in MMD, and you know why. And of course, some patients with Takayu's arthritis can also have a presentation with limb-shaking TIAs. Then, of course, our beloved neurocystic psychosis. Neurocystic psychosis in any stage can present as a stroke mimic. It is not uncommon that patients with NCC get mistaken as stroke. And if you've just done a NCCT head as your first investigation, thinking it's a stroke, you may miss out an NCC if it is small and calcified and your 10 mm sections of the CT scan actually just go through that and miss it out completely. So particularly when you have a hypodensity near the inhibitory motor cortex. So this is the inhibitory motor cortex just in front of Broca's area. This is the inhibitory motor cortex just in front of the supplementary motor area. Wherever you find a hypodensity there in the NCCT, please go ahead and give contrast and substantiate whether it could be a NCC presenting with an inhibitory motor seizure as a manifestation. What is the characteristic of a mimic of a stroke? Mimic of a stroke, the characteristic is it's out of the age barrier. You will find it occurring more often in younger patients. So wherever you have a younger atypical stroke, wake-up stroke presentation, or you have a confusion, it's a non-convulsive status or a focal seizure with a postictal Todd's palsy, please think of a mimic. Also, wherever you have no risk factors, that's another red flag where you should think of a mimic. Wherever the patient has not arrived by an ambulance, is so well preserved that the relatives bring him on a scooter or a car. Again, that's one of the studies which has shown that it could be a stroke mimic. And of course, where you can have these mimics and overlaps in as much as 30% of your stroke population. Not uncommon is to find both seizures and strokes due to underlying common risk factors. So patients people or general public who are abusing cocaine or who are on cough syrups can have both seizures and stroke. Patients with MELAs or mitochondrial disorders can have both, and there's a common list of conditions, whether it's infections, whether it's Sturge-Weber syndrome, whether it's CADASIL and arteriovenous malformations, which can have both. So that was the first part of my talk, where there's overlap, where there are mimics. Then I come to the second part of my talk, which is the post-stroke seizures, and these are not uncommon. As you can see, 11% of the adult epilepsies are due to stroke, and it's higher, it's 3 times higher, 30% in the elderly. And the incidence of post-stroke seizures ranges anywhere between 4 to 45%, depending on what kind of seizures you're counting. In India, the NUCA study has shown us that as much as 13% of our patients with stroke will have post-stroke seizures.